So today we'll start our session, the final session of SOS on syncope in children. What is syncope? We have to remember that syncope has to have three criteria. It should be sudden, there should be associated loss of posture and loss of consciousness. So what I want to emphasize is that the sudden loss of posture and loss of consciousness is followed by recovery. But when there is no recovery, what do you call it? When there is no recovery, it's death. That's the only difference between syncope and death. So dear friends, please, I insist that do not take all syncopes as just a simple fainting which we see ever so often. Suraj, can I have the next one please? Thank you. So when we go on to take the history in a child who comes with syncope, we always look at the precipitating factors. We ask for what was the prodrome, that is events which happened just before the patient had syncope. Also very important to ask, because many of them have sort of amnesia about what happened. They will describe that I fell down and then I don't know what happened and I saw few people looking into my face and splashing water, etc. But what is more important, thank you Suraj. What is more important is to rule out the red flags. Do not forget to ask for family history. Do not forget to ask for what was the relation to exercise and if there were any medications which were taken. We'll just dwell upon this a little bit more. Whenever we take history in case of syncope, please ask for family history. Ask for sudden death in family. And while most of us will ask for sudden death in family, do not forget sudden infant death, because that is also a form of sudden death which happens in infants, and most parents forget that there was a relative who had an unfortunate event of SIDS. Also, ask for anybody who has had history of prolonged QT interval. It's a very specific question to ask, but if you ask them whether they required any restriction on any medication in any family member, you would know. Two subtle histories in the family would be in the form of any episode of drowning in the family members or any deafness in the family. Both of them, if coupled with syncope, will point towards a congenital long QT syndrome and thereby make you alert for that long QT syndrome. Once we know or suspect a long QT syndrome, not only that we can put them on medication or if required pacemaker, but more importantly, we can put them, avoid medicines in order to certain medicines which will prevent prolongation of the long QT syndrome. The next most important question is about exercise. You have heard a lot of times, you hear in the paper, the fit person in the gym who died or the marathoner who had a heart attack and died. Many of the exercise related syncopes are due to hypertrophic obstructive cardiomyopathy, and that is a condition which may be otherwise asymptomatic, but at the during the exercise they may develop syncope and sudden death as well. If you get a history suggestive of fainting attacks, dizziness, blackouts with minimal exertion, suspect aortic stenosis or outflow tract obstructions. But you must have seen many sports events where they would go for there will be a long athletic event, 400 meters, 800 meters or marathons. The moment they finish they cross over the finish line, the athlete faints. Okay, now we have seen that all so often. That's not typical of HOCM. What happens is, because of dehydration, there is a loss of water and there is less intravascular fluid. The moment the athlete stops his activity, the muscle contraction stop and the venous return which is coming gets hampered, and there is a sudden drop in cardiac filling which results in syncope, and that is known as heat syncope. Also ask for chest pain, associated chest pain, because as you would commonly ask for history of chest pain in adults, in pediatrics most of the times we ignore chest pain, and as in our earlier, you must have heard in snippets of symptomatology, we said chest pain is almost always of pleural, lung or thoracic origin and not so commonly of cardiac origin. But if chest pain is coupled with syncope, please look at these two entities. The first one being Kawasaki, and dig deep and find out if the child had any symptom which suggest a possible Kawasaki which was missed early in the childhood. Al-Kappa is a congenital disorder where the coronary artery starts in a different way. I don't think we can get any history for that, but on ECG there are characteristic findings. Also important to ask for any history of recent onset medication or any other prolonged medication for any other diseases. If the patient is on any macrolide or recently started macrolide, especially notorious are clarithromycin and erythromycin. Azithromycin is comparatively safe for long QT intervals. Also, if the patient is on any antiarrhythmic or any calcium channel blocker, it's a good idea to take detailed history about that. So these are the three important red flags that I would like to rule out in syncope. See, when we started discussing the first topic on arthritis, we said first we asked ourselves whether this is arthritis or not, if it is arthritis, is musculoskeletal or not, etc., etc. And then we went on to the red flags. But when we are taking history of something as important as syncope or as urgent attention requirement, we first look at the red flags, rule out the red flags. Now we know we have time to discuss further. So now we take history of precipitating factor. The common precipitating factors that we know are long hours of standing. Classically we hear after a long prayer or in a parade or just before any school activity, when children are made to stand for long hours, they experience syncope. You must take details of the prodrome. Ask for certain medical problems of heart disease as we discussed. Ask for history of diuretics, vasodilators, these drugs which increase the peripheral vasodilatation and precipitate a syncope. Also ask for observer's report. It's very important to take detailed history to find out what was the position of the patient when this event occurred. Okay? Syncope by definition should occur in standing position. A person who has syncope in sitting or lying down position is a red flag, and it could be a red herring as well. Okay? We must ask whether the patient appeared pale and white before the patient had a fall, or whether the patient appeared dusky and cyanotic. Both will point you towards different etiologies. As far as the recovery is concerned, whether the recovery was instantaneous after a few seconds or it took a few minutes, that is important. But what is more important is how complete was the recovery, whether there were any deficits subsequently or not. And then lastly, we go the other way around, is ask ourselves whether this was actually a syncope or whether it was something else. So if the patient had syncope in lying down position, if there were urinary incontinence, if there was frothing in the mouth, or if the eyes were open at the time of syncope when the patient had a fall, you would think in terms of a seizure disorder. Small children in sitting position will start crying and become blue, dusky and stiff, and then we would label them as breath holding spells. On the other hand, if you have an adolescent or slightly older child who was breathing fast, complained of tingling numbness in the hand and feet before he had an episode of syncope, then you would think of hyperventilation induced. And of course, as we all say, when children have repeated fainting and we have no other cause, we tend to label them as psychogenic. So let me again go through the red flags, which are the most important part of history taking in syncope. Any child who has syncope during exercise, any child who has syncope in lying down position, anybody who has a positive family history, or any known cardiac condition or on certain medication would be red flag for a syncope. On the other hand, if you found any congenital cardiac conditions like Kawasaki, etc., then you would be worried about it. So whenever you get a child with syncope now onwards, please make sure that you have an ECG at least for the first episode. If you get a history, association with exercise or a positive family history, please consider that as red flag and do not label it as simple fainting even if the ECG is normal. And as I said earlier, if fainting occurs in lying down position, think of syncope. Think of a seizure, sorry. And if you have any of the red flags and the ECG is normal, please do not hesitate in going through a full cardiac workup, including echo and a 24-hour Holter monitoring. If you suspect seizure or seizure-like disorders, please go ahead and ask for an EEG. Because remember, as we started on our first slide, this patient, I would say, was lucky that he had a syncope, and you are there now taking history and examining. But if we don't take proper care in history, next time that patient may not be as lucky. Thank you for your time and attention. I invite Dr. Tushar Shah to introduce our guest speaker.